Thank you. I think everyone will need coffee after lunch. Anyway, thank you very much for having invited me for this session, and I'm delighted to speak to a group which is really not from the medical professional group and more, I think, from the IT world or the digital space, which really excites me a lot because I get very interested in that field. And I've met a few of your delegates this afternoon, just 10 minutes before, and I'm delighted to chat with them later. So my presentation today will be related to PCOS. Can you make it full screen for me? Let's make it full screen.
I think that it is.
You can just mark it here, yeah. Put it from start from the beginning. Yeah, that's it. I'm so used to an iPad. I hate a computer. What's it doing? From the beginning? No, it's not playing? You've opened in PowerPoint? Okay. So again, sorry for this interruption. Thank you very much. There's a little correction. Of the PCOS Society of India is in existence for the last 7 years, not 26 years. I'm the founder president, and I'm happy to say that I think in the last 7 years, we have really reached out to thousands and thousands of people and lots of women. So today I'm going to speak on unraveling the puzzle of PCOS, which is something which many people do not know. Someone calls it PCOD, someone calls it PCO, someone calls it something else, but the current situation is we call it PCOS. So the first question I will ask is, do all physicians know all about PCOS? For us to educate our patients, we need to be educated ourselves. So in short, this was a very nice survey carried out by the American College of Gynaecologists. American college, not Indian college, American college in 2015. And they surveyed 630 physicians. And the results were that 30% did not know the correct way to diagnose PCOS. Many OBGYNs were not aware that PCOS is associated with mental health, that's depression, anxiety, and disorders in PCOS. Many were not aware of the long-term consequences of PCOS, and more than 85% knew that it's associated with obesity, yet only 50% physicians recommended lifestyle changes to their patients. Unfortunately, in the US, every consultant gets exactly 10 minutes to talk to their patients, in which they have to examine, diagnose, and treat. Hence, they never get time to talk about other things related to their health, and therefore that could be the reason why they do not recommend. So the conclusion of the study was that the physician education is absolutely necessary. We must make sure that there's consistent and holistic care given to the women, and they should be monitored across the entire period of their lives. Because today we know that PCOS starts right from puberty and goes beyond menopause. And therefore, we created the PCOS Society of India, which was meant for physicians who treat PCOS patients. And it's not only gynecologists, it's endocrinologists, dermatologists, anyone who deals with PCOS patients, including allied health professionals like physiotherapists, nutritionists, etc. So we have all kinds of people getting together to learn about the new and the nuances of PCOS, and that is what the society stands for. So we have a great website which carries all the educational programs we do. And if any of you is interested, you all could go back. This is the link. If you can take a picture, you could click on the link and get onto the website and know what all the PCOS Society is doing. So because PCOS is so confusing, everyone has to get together to decide what should be, how should we diagnose it? What should we do? The terminology has been going on changing. But if I go into the history of PCOS, I was reading on it, it started more than 300 years ago. And till today, no one knows what's going on. In short, we are trying to get there. We don't know where it starts, why it starts, etc. But yes, there are risk factors. So 37 global organizations got together and we met in 2017. All year round there were meetings, and we decided to create the International Evidence-Based Guidelines, which is based on scientific research. There's a huge amount of work which goes in this, and that is the kind of work was done, and 3,000 physicians and consumers were involved in creating these guidelines. And today it's like the Bible, which we all refer to, which tells you exactly what to do with PCOS patients. It's based on the current evidence on PCOS, and there's a lot of research going on, and I'm sure now that we are updating these guidelines in 22 so that it's released in 23. It will make a lot of difference. So this was the 37 organizations. This list is there, and the PCOS Society of India was one of the only associations from India which was invited to participate in this meeting, besides FOXY, which is a huge national body of our gynecologists. And I was one of the members. I'm sitting right there, but maybe you won't see me too much, but we were invited to work on these guidelines. And now this is led by the Monash University, which is based in Australia, and the very important organizations like the American Society of Reproductive Medicine, the European Society of Human Reproduction, all of them have been involved in promoting these guidelines to global doctors all over the world. So this is what is being done, and now we are updating those guidelines. Every 5 years, guidelines should get updated based on the current evidence. And fortunately, I have also been involved in this update, and I've just come back from Prato, which is close to Florence, and where there's a Monash University Center. We met there. This is just one group. There are 5 such groups working on it with thousands of other health workers associated with it, which now these guidelines will be released in 2023. They are available free of cost on the website of PCOS Society. Anyone would like to see them. The 2018 guidelines are there, and then 2023, once they are published and released in the medical journals, then it will go up on our website again. So what we wish to tell you is, what is PCOS today? Stands for polycystic ovary syndrome. It's not a disease, so we don't call it PCOD. We do not know what causes it, so we cannot call it a disease. Say, for example, if you've got malaria, we know that the mosquito causes this disease and there's a cure for it. Here, we do not know what causes this, and therefore we don't have a cure. And therefore, we call it syndrome because it presents in different ways. And what it is associated mainly is a hormonal imbalance, where the male hormones are higher than what occurs in women naturally. The female hormones also are higher than what occurs naturally. There are increased insulin levels, which is another hormone being released by the pancreas gland. And the ovaries, when you see them on ultrasound, they look polycystic. Polycystic means they have many, many small follicles, which are making it look like cyst, and therefore this syndrome has been named as polycystic ovarian syndrome. Now, the cause is not known. It's whether it's the imbalance of the hormones which is leading to the polycystic ovaries, we do not know. Or is it the polycystic ovaries which are producing the imbalanced hormones? So there is a chicken or egg situation here. We don't know what causes what. But at the same time, we call it syndrome because we do not know what causes it. Now, 5 to 10% only is supposed to be genetic. That means chromosomally, or from the genes, it gets transmitted from mother to child. At the same time, it's been shown that it is the environment which affects the baby more than anything else, or lifestyle problems. The environment within the mother's womb, that's the latest information we have, that something in the mother's womb, either the male hormones being high or the insulin being high, which is causing the problem. So therefore, those babies born to those mothers are likely to be born with those kind of hormones within them, or it sort of, gets ingrained into their genes so that they convert into PCOS girls. So you'll find that almost 30% of girls or women with PCOS have got families of women in their families who also have PCOS. So this is not because of genetic transmission, because there's no gene identified as yet which is causing PCOS, but it is the environment within the mother's womb. And later on, when the babies are born and when they reach puberty, when their ovaries become active, that's when they reach puberty, that's when their problems start. Again, the balance of hormones is affected, lifestyle changes. Today with computers, with phones, nobody's running around, no kids are having fun. There are very few having sports as their activities, but it's basically lifestyle change, putting on weight and inactivity which is causing the problem. If you look at human body as the child grows within the mother's womb, if you see different parts of the body grow at different parts, first trimester, second, 9 months is pregnancy, I think everybody knows that. First 3 months is called first trimester, next 3 months is second trimester, third is third trimester, last 3 months. So the development of the baby starts here, right, immediately 6 weeks after conception. The brain is what is developing here. Why are we talking about the brain? Because the brain is the master gland which controls all the other hormone glands. And here you have the brain developing here at this stage. At this stage, if the baby's brain is exposed to a lot of androgens or male hormone or to a lot of insulin, which is due to insulin resistance, it can cause problems over there. The pancreas is developing between 40 days and 100 days. If the pancreas which secretes insulin gets affected at this stage, it can then start producing insulin in an abnormal way. Adipose tissue, that is the fat in the baby's body, starts developing in the middle part of the 3 months. And that is why we as obstetricians are constantly watching the mother, seeing whether the mother is putting on too much weight, which she shouldn't be. And if she's putting on too much weight, maybe the baby is also putting on too much weight, which we will see in the when we do the ultrasounds. That's how we come to know. So if there's a lot of fat getting deposited in the baby, then we know that this is going to be a problem for that child, and therefore we don't allow a pregnant woman to put on too much weight, especially in the mid-trimester, because it brings the lot of fat collecting in the baby, which can then later on cause problems for the baby. So it's been shown, now this is the current research I'm talking about. I'll go to the actual facts of PCOS very soon, but I thought I'll excite you all with what new research is happening first. The children of PCOS mothers, when they reach puberty, the children who are born, the girls, it has been shown, as I told you, that inside the uterus, if there is an imbalance of hormones, more male hormone can cause a problem like PCOS. Then this is the time at puberty when there are a lot of changes. I'm sure many of you have had teenage girls who must have given you a lot of trouble. Of course, the teenage boys also do that, but the teenage girls who become very moody, who are giving you a lot of anxiety, etc., with certain situations, and therefore this is the time when every teenager goes through it, but PCOS girls get a bigger problem as compared to non-PCOS. Daughters of these girls have been found to have more problems, like they have a lot of metabolic disorders. There are higher chances of them developing diabetes in later life, high blood pressure in later life. All these problems start after puberty. They put on excessive amount of weight. I've got a young girl who's only about 15 years old and she's 130 kilos as of today. So it's quite a task to manage these girls, but a lot of exercise, lot of voluntary, willpower helps them to go through. The question came up, what happens to the sons of these mothers? What happens to them? And let me tell you all something, there's something coming up like the male pattern, male PCOS coming up very soon. A lot of research going on that brothers of girls who have got PCOS could also be having PCOS. They don't have ovaries, but they have the similar pattern as seen with PCOS girls. So in men, they have seen that these boys, who, as they grow up, they have extra facial hair, excessive facial hair. They also have a higher chance of developing diabetes, high cholesterol, as the girls do. They also get high blood pressure and high cholesterol. What is a symptom to look at? If the boy starts balding before the age of 35, that is a sign that this boy, especially if he's got a girl, sister who's PCOS, has got a higher risk of having a problem, what we say male phenotype of PCOS. So now coming to the basic facts, how do we diagnose PCOS? 3 things. These are called the Rotterdam criteria, which are universally followed. And any 2 out of these 3, if they are present, then we say that the girl has PCOS. So if she's got irregular periods, if she's got presence of acne, a lot of acne in her face, which can happen to a teenager also, and therefore we make a final diagnosis only after the age of 18. Before that, if a girl has any of these problems, we say she's at risk of having PCOS. So nobody makes a diagnosis of PCOS unless she reaches an age of 18, or she's got all the three factors present in her before the age of 18. So if they have irregular periods, presence of acne or hirsutism. Hirsutism means hair where normally women don't have hair. That is on the face, on the chin, on the upper lip, on the chest, on the back, on the shoulders, lower abdomen. It's quite very, very taxing for these girls. I've got girls who are shaving every single day their faces. Very embarrassing. Of course, COVID helped them to hide their faces, but unfortunately, COVID also brought in a lockdown wherein they couldn't go to the parlors. It was quite tough for those girls. They had a lot of mental anxiety and stress. Then, of course, on ultrasound, you will find polycystic ovaries. Now, what does it all mean? If you look at normal periods, they will usually be more than 21 days or less than 35 days. So some women will have their period every 24 days and get it every cycle every 30 days, which is fine. But if she's having a period which is coming, there are less than 8 periods in a year. That means she's getting delayed periods, so she's missing out 4 periods in a year. Or she's not had a period by the age of 15 years. Then we say she's got irregular periods. If there are male hormones extra in the blood, which is called hyperandrogenemia. Androgens is male hormone, androgenemia is male androgens in the blood, and hyper means more. So this is the translation of this medical term. So in that you can get this hirsutism, which hair grows just as it is seen over here. You can see the hair growth on the face, which is quite embarrassing for the girl. And then there is acne on the face and loss of scalp hair. So this thick coarse hair can be as bad as this in the chin, jaw, upper lip, around the nipples of the breast, midline of the chest and midline of the abdomen. And this is the male pattern hair distribution. This is how men have hair on their face or on their bodies. Then they develop this terrible acne, which is so difficult to treat, and this is what they get, and they're very embarrassed about this too. And then they have a female pattern of hair loss. Now the hair loss occurs in this, like say it starts with this is grade 1, where they start balding towards the hairline. Then it gets worse, and then the whole center of the vertex or the head is involved, and that's called stage 3. So in short, they develop this hair loss, which is again very embarrassing. So you can imagine the kind of mental stress they go through. So one is irregular period. Second is extra male hormones in the body, which is clinically seen in these various forms. And the third is if you do an ultrasound, you will find that the ovaries are large. They've got lot of follicles inside, as you see over here. Normally, a girl would have about 5 to 6 follicles seen. In these girls, you will find about 10 to 12. But as the years are going by and as the ultrasound machines are getting more and more sensitive, today they say that if you're using a particular sensitive probe, it should show more than 20 follicles. Then we can count it as polycystic ovary morphology, we call it. Polycystic ovarian morphology, that is the look of the ovary. Now there are many radiologists who write a report, they see the ovaries like this and then they'll write polycystic ovaries syndrome, which is something we are trying to teach the radiologists. Please don't write this, because every mother thinks that her daughter has PCOS and gets very, very anxious. So this is something we tell them, and therefore we are telling them that this is what you write in your report, polycystic ovarian morphology, not polycystic ovarian syndrome. Now, if you look through the life cycle of a woman, she has the whole problem starts at puberty, which is the adolescent period. And as I told you, they have menstrual irregularities, they have cosmetic concerns, they also have mental health issues like depression, anxiety, etc., which occurs because of their external look and the obesity with it. And of course, it can also occur because of the mood changes, because of the hormones in the brain which are causing that problem. Then comes a reproductive period where women, if they are having irregular periods and imbalanced hormones, there's infertility. And if they do get pregnant, there's a higher risk of having a miscarriage. And when they are pregnant and carrying on the pregnancy, there's a higher risk of them developing diabetes during pregnancy and hypertension, high blood pressure, which is called pregnancy-induced hypertension. When the woman becomes 40 years old, she is plus Post 40, she's got a higher risk of developing metabolic syndrome. That means she starts getting high cholesterol levels, high sugar levels, high insulin levels, and she also starts getting other issues, obesity, etc. So all this, unfortunately, is exacerbated by the word obesity. 80% of our girls and women who have got PCOS are obese, but there are 20% who are still lean. And they are the ones who tend to get missed out because they are lean, and every doctor thinks that she needs to be obese to make a diagnosis of PCOS. So with this 80% of women, what is very important is initially we used to only look at the BMI. BMI means height and weight is taken into consideration, and there's a ratio there's a formula which comes up with a BMI. Anything which is less than 25 is supposed to be, according to international classification, as normal. But Asian women from India or included, we have a lot of fat within our bodies. I'm coming to that. What is that? Visceral fat. And therefore, there are different standards for Asian people. If your BMI is more than 23, we say overweight. If it becomes more than 25, you're called obese. But according to the international classification, up to 25 is normal, 25 to 28 is overweight, and above 30 is obese. So this is how it is, but today we find that taking the waist circumference is better than taking the BMI, because BMI varies a little bit, but waist circumference tends to remain most constant. And the reason why we do this, because if you see the belly of this woman, she's got a lot of visceral fat, and you'll see the upper abdomen gets affected more than the lower. She may have a paunch lower down, but if this upper part of her abdomen, if you look at any woman who's overweight or obese, if you find that the upper part of her abdomen is bulging a lot, it means she may be insulin resistance. So what really causes that? If you look at the body fat, we have two types of body fat. One is the subcutaneous fat, which is under the skin. And that subcutaneous fat is present in the thighs of the patient, in the tummy, in the breast, in the arms. But if you look at what is visceral fat is what is sitting inside the abdomen around the organs in the body. Say usually around the liver, it can cause fatty liver disease. It causes, if it goes into grade 3, it can cause liver failure. So in short, it has got long-term consequences. So all that fat collecting within the abdomen, around the organs, is the worst type of visceral fat you can get. So this is what we are looking at, and that, see, it's all up in the upper abdomen over here, as you see. So this is what causes the waist circumference to go up. And that's what we are looking at today. If it's anything above 80 centimeters on the waist at the umbilical level, then we say that this is a lot of visceral fat, and there are ways, there are calipers to measure, there are standardized ways how we measure. Now this is responsible for something what we call insulin resistance, which is a pre-diabetic state. I mean, if you want to understand what it is, I'm not sure. Do you all want to understand it? Because you'll understand the subject better. Or it's not of interest, then I won't go into the details. You would like to? Okay. It's a very simple thing, but it's a pre-diabetic state. What really happens is that when you eat something, the sugar levels go up in your blood. And normally the signal goes to the pancreas gland, okay, the sugar has gone up, send some insulin across, and the insulin will work on the sugar and bring it down. I'm sure you must have seen some diabetics in your family who are probably on insulin, I'm not sure. But insulin is what brings the sugar down. Now what happens in these women, for some reason, whatever is the insulin that pancreas is producing is not able to bring on its effect of lowering the sugar. So it gets produced, the levels are high in the blood, but it needs very high levels in the blood to bring on its effect of reducing the sugar. So the signal keeps going to the pancreas, not enough insulin, pancreas goes on secreting insulin. That insulin is responsible for you to put on more and more weight. More and more fat collects around the waist. And that is what is causing the fat in the body. And that is a pre-diabetic state, because one day that insulin will stop working completely and the sugar levels will keep going up. So initially it is called insulin resistance, which is a pre-diabetic state, and then it goes into diabetes, which is a situation where the insulin is just not working and it's of no use. So in short, what women have with this visceral fat, therefore if I see a woman, just by looking at her today, I can tell you she's insulin resistant, right? Just by looking at her tummy, where exactly the fat is loaded, because fat itself, the fat which is inside the abdomen is also producing insulin. The pancreas is also producing insulin. All this insulin is collecting in the blood, not bringing on its effect, and just making the woman grow more and more obese. So this is like a vicious cycle which needs to be broken. And that is why we give insulin sensitizers to a patient, something like metformin. Initially, when I started using it almost 15, 20 years ago, the mothers would go to the chemist and the chemist says, who's diabetic in your family? Because the same drug is used by diabetics also. There are many better drugs for them, but this is one of the drugs to make insulin work better. So then the mother would get frightened and say, oh God, what has the doctor's given me wrong medication for my daughter? And then she'll promptly switch her doctor. Now today everyone knows that metformin is standard of care to give it to all girls who are having insulin resistance. So this is something we must understand, and that's why I'm talking to all of you, because if a girl is on metformin, or anyone, we have given metformin even to 8-year-olds who are obese, and they've got insulin resistance, and unless you give it to them, that cycle cannot be broken. So in short, we look for all these things: fatty liver on ultrasound, hormone imbalance, increased waist circumference. Now this obesity is also associated with diabetes, high blood pressure, cardiac disease. They can get a stroke, they can get myocardial infarction, they can get kidney disease. It affects any part of the body. Now since we have had COVID infection recently, all of you have gone through it. Girls with PCOS have had a higher problem as compared to women who don't have PCOS, and there's enough evidence for it, and therefore we recommended that vaccines should be first given to PCOS women rather than to anyone else. So 80% are obese and a large percentage of them are insulin resistant. Even the lean girls can be insulin resistant. So in short, 50% PCOS women are insulin resistant, whether they are obese or they are lean. The obese ones are more resistant, the lean ones are less resistant, but it occurs. Another very important sign is where girls come with a lot of pigmentation on their neck. Can you see this pigmentation on the neck? And it's not just pigmentation, it's like raised, little bit raised above the skin. And this is typical of what you call acanthosis nigricans, which women have this pigmentation, which if you give them metformin, it vanishes. Within 6 months, the skin is all clear. So they have it in their underarms, they have it in their groin, and they have it in their neck. And this is again an embarrassing situation for them. So acanthosis is something which goes with insulin resistance. Mental health issues, as I told you, depression, anxiety, stress, lack of sleep, mood swings, all this happens because of the obesity, the facial hair, and the hormonal imbalance in the brain. In our own data, we have seen what has happened. We took a total number of young women between 15 to 35 years with an average age of 23 years, 440 girls, and what we found is that mental health issues were present in 55% of them before the lockdown. After the lockdown, it increased to 63% because they were not having parlors where they could go get their waxing done. They were not getting access to blades, even to shave. It was very difficult situation for them. They were not able to do the exercises which they wanted to do. They were locked up in small rooms with the whole family, no place to exercise. So they went through a lot of stress. All of us went through stress, but I think they had more of a problem. Then coming to the adolescent girls, we need to, what is the goal of management? There's no one-point cure. Whatever problem she comes to us with, we correct the problem. So if periods, we correct the periods. If they've got acne and hirsutism, we correct that by giving anti-male hormone therapy. Oral contraceptives is a wonder drug which works brilliantly on them, but we must know which girl to give it to and which girl not to give it to, and therefore it has to be done under medical supervision. We have to address their mental health issues, and we have to prevent obesity. That's again something as a lifestyle change holds true for everyone, even the lean girls, even the obese. All of them require lifestyle changes. Now coming to the reproduction part, when you have PCOS and you have obesity, it adds on to the problem of reproduction. So there's early puberty. Girls as young as 8 years old are getting their periods because of this. They're starting to get hair growth on their pubic area at the age of 4 years. I mean, all kinds of things we've seen. infertility coming up because it affects egg quality, it affects the embryo to implant in the endometrium. There are increased miscarriages, and then there are complications, as I told you, during pregnancy which occur. In our own data, if you see, where we looked at BMI and we looked at waist circumference. Now see, these are normal weight PCO patients, and here you have patients who have got a 60% pregnancy rate after doing therapy. But if their BMI, if their waist is above 80 centimeters, you see their pregnancy rate drops to 46% from 60%. So that is the difference that visceral obesity causes, and that is because of insulin resistance. So you put them on metformin, bring them under control, you may not even need to do anything, she'll conceive on her own. If she loses weight, 25% chance higher that she'll conceive on her own if she just loses 10% of her weight. So the goal is losing weight, getting rid of that excess weight. If there's no excess weight, she's lean, then she needs to do muscle exercises, she needs to do resistance exercises, but she definitely needs to do exercises. Then we come to that question that waist circumference is extremely important, and if the waist circumference is high, the chances of having a baby, a live birth, is definitely lesser after even IVF as compared to women who have got a low waist circumference. When you have infertility, what is the goal of management is you first correct their hormonal imbalances, bring down the male hormone, remove the insulin resistance, make her lose weight. But if she's already 36, 37 years old and you're running against time for her, where her biological clock is ticking, you can't keep telling her if she's 130 kilos, please lose weight and come back. No, you have to 3 months of vigorous exercise, health management, weight management, eating healthy, and then do the treatment, she will do very well if she's going through a routine treatment. But if she's going through IVF and she's already 38, 39, we don't waste time, because with IVF at least we can get her eggs out before they are all gone, create the embryos, freeze and keep them, make her lose some weight and then transfer within them. So today it's becoming much easier to treat these women rather than in the past. Then we have mothers who get pregnant, as I told you. They have 3 times higher chance of getting diabetes in pregnancy if they are PCOS, 3.5 times higher chance of getting high blood pressure, and 3 times higher chance of losing the baby if they've got PCOS as compared to non-PCOS. So they are at increased risk of complications. And in Asian women, we find ethnicity-wise, Indian women especially who are in Asian women includes all over Asia, but Indian women mainly, Sri Lanka, India, Pakistan, this area has got a higher risk of getting diabetes in PCOS women, 5 times higher, 4 times higher in American women, 3 times higher in European women. Hence, blood sugar has to be monitored regularly through the pregnancy, right from the beginning till the end, and we do it regularly in our patients every 2 months, because so often we find that when they have reached the 7th or 8th month, the sugars start going up. So that's another message to go out to women who are pregnant. Please regularly, even before getting pregnant, check your sugars, because you'll find a lot of them having high sugars right from the beginning of their pregnancy, which they've never checked. Even it affects the newborns. 2.5 times higher chance of admitting a newborn in the ICU, and 1.5 times chance of prematurity. So in short, there's a lot of morbidity associated with PCOS, and we need to follow up these patients very regularly. In our own experience, we have found that PCOS women, almost 20% of them, 1 out of 5 women develop diabetes, whilst normal women only 6% develop diabetes. So in short, India is second largest in the world for diabetes, and if we can prevent diabetes in the next generation by controlling the sugars in the mother today, we'll be able to reduce the amount of diabetes in our country by preventing that the imprinting of this disorder in the next generation. And therefore, it's extremely important for us to do this and spread the word. If there's any media person here, please do that. The 40 plus PCOS woman doesn't get away from this. She, as a matter of fact, will have a higher chance of getting increased bleeding. She'll have erratic bleeding or heavy periods, or sometimes very coming periods coming after 3 months and then running like a tap. She has difficulty in losing weight. That happens to all insulin resistant women. She develops metabolic syndrome, and she has a higher risk of developing cancer. of the uterus. So in short, these are the problems which can occur. They all increase the risk of heart attacks, and therefore 40 plus women also need to be checked. Once you know she's a PCOS patient, lifelong she has to be at least once a year coming in for an annual checkup so that we can pick up things earlier if anything happens. So this metabolic syndrome, as I've told you, this is a cluster of risk factors which are related to cardiovascular disease, and therefore these are all what we look for. Endometrial hyperplasia in cancer, where there are irregular periods, the lining gets thicker, then they don't bleed for 2-3 months, and then that whole lining is shed off, and then they bleed like a tap, they develop polyps inside. And the commonest thing what many gynecologists do is tell her, okay, you need to remove your uterus because you're bleeding so heavily. But the question is not removing a part. If you've got a headache, you don't chop off your head. You find out what's the cause of your problem and correct the problem, and then automatically the bleeding will stop. We have been able to save, I think, hundreds of uteri like this by just trying to get to the cause of the problem rather than treating the symptom. And therefore, these are the women who have a higher risk of developing cancer of the uterus. They need to be monitored even after they reach menopause, because again, they can get endometrial cancer, and therefore they need to have a regular checkup. The risk factors for cardiac disease: cigarette smoking is very bad for women. Their ovaries take a toss completely. They go into premature menopause. They have problems getting pregnant, but also it affects their heart just as it does with men. So these are the problems which are associated for 40 plus women, and therefore all PCOS women should have the following done. They should get their cholesterol levels checked every year, blood sugar levels, blood pressure check, sonography of the uterus, a pap smear, which I've forgotten to add here, and the waist measurement. I think being on the global guidelines, at least I could speak on behalf of Indian women and say what we see in our country and then develop the guidelines. The guidelines were originally writing that once in 3 years you do blood sugar. I said nothing doing. I said we need it every year. Please change the guideline. Make it inclusive of everyone in the world. So they wrote in certain ethnicities you need to do it every year. So ethnicities means people coming from a particular background. So the main thing is lifestyle change for PCOS. We need to prevent obesity by having healthy nutrition and exercise. I know there are a lot of diets going around. What you must remember is how much is going in, how much is coming out is important. It's like a bank. You put in money there, you've got to take that much money out, otherwise it will keep accumulating there. So in short, it will gather interest also, but we don't want that happening to our fat. We want it going in and we want it coming out. So in short, you have to count your calories, whatever you eat. If you eat a big bowl of salad, your tummy will be full and you'll get only 50 calories. You eat 1 bar of chocolate, you get 400 calories, which will not satisfy you for a long time. So in short, you have to learn what to eat, what not. Be under the care of a nutritionist if you're having a problem controlling your diet. It's not about starvation, it's eating healthy. So that is important for us to remember, that don't eat the wrong food, not the deep fried stuff, not the sugar stuff. All that has to go out of our system, out of our diet, and we need to eat more of natural products, more of salads, more of fruits, more of pulses, and of course non-vegetarian food, more of fish if we wish to eat, but no red meat. So that I think is a whole lecture by itself, so I won't delve into that, but main important thing is to keep yourself under control. So healthy diet and exercise regularly. Even for a lean patient, she needs to do more of strength training. She doesn't need to lose weight, but she needs to do strength training because the muscles help her to reduce her insulin resistance. So once they lose weight, people give up. Then again it comes back. So you have to continue to maintain that exercise, at least 150 minutes of moderate exercise per week. So that is, if you look at 60 minutes of moderate exercise per day for 6 days is when you want to lose weight. But when you want to prevent weight from coming back, you need 150 minutes of exercise per week. So that is, we are talking about something like 30 minutes a day, at least, multiply by 5 days, that comes to 150. So you want to maintain your weight, you continue with that exercise, but to a lesser extent because your metabolic rate has already gone up. So this is something we do, and the take-home messages I'd like to give today, that it's important for us to make a correct diagnosis, because once we have confirmed that a patient is PCOS, she needs to be followed up regularly. So don't call a woman PCOS unless you're 100% sure she's got PCOS, number one. There are many problems which are there with these women, with these girls, and this is something we should be aware of, and we should follow up with the doctor. Just getting laser done, removing the hair is not the answer. More hair will keep coming until you correct the internal problem. Reduction of obesity assists in getting higher pregnancy rates and after infertility treatment. Management depends on how the patient presents to us. If she's come to me with a lot of facial hair, I will treat accordingly. If she's come to me for infertility, I will treat accordingly. If she's come to me at 40 with excessive bleeding, I'll treat accordingly. So the treatment depends on what she's come to you for. But the most important thing is get rid of the hormonal imbalance, get rid of the lifestyle, correct the lifestyle health problems. I think that's most important. And long-term monitoring, at least an annual checkup once a year, to prevent medical disorders from getting worse and to prevent uterine cancer. And important to remember that every pregnant woman should have been tested for blood sugar and high blood pressure at very regular intervals to prevent the next generation from picking up the problem. We do have a program called PCOS Connect, where we are connecting to the unconnected, and now this coming year we are going to reach out in a big way to consumers. Till today we have reached out more to the doctors, educating them, and with different disciplines, and now this year the agenda is to reach out to consumers. So thank you very much for your kind attention, and I'm sorry for the very, very long talk.
Thank you so much, ma'am, for that wonderful presentation and insightful one as well. Do we have any questions? Anyone? Yes. Yeah.
First of all, lovely session, ma'am. I think you've successfully depuzzled, unpuzzled the PCO landscape. Definitely, as you said in your presentation, I'm sure that you can look at me and you can tell I'm a PCO person. Last year, when I was 23, I was 65. The sizes that I used to wear were size medium to size large. I think then I got COVID first time. Then 6 months later, I got COVID again, and then I got COVID again. So in this 1, 2, 3 times, I have overall gained 35 kgs, and then again my weight continuously kept on increasing. The kind of treatment that I seek for it is that thankfully I was diagnosed with PCOD or PCOS at an early stage, so I could manage it. I did have endometriosis, I had insulin resistance at a very high level, and I had all the things that you mentioned in your presentation, but then somehow I was able to control it because I was lucky enough to seek that kind of a diagnosis. I also, my question comes as a healthcare innovator, because I want to understand that yes, there are certain ways, there are certain biomarkers that we can keep a track of, and with health monitoring, we can find out if somebody is prone to PCO and if they are at an early stage of PCO. But I also want to understand the landscape of early diagnosis of this disease from you, so that somebody who's working in the technology landscape towards early detection can maybe take your inputs and maybe just have that kind of a roadmap ahead in terms of research.
Yeah, I think the the markers, what I would say, very clinical markers, even without doing any test. If a girl has had very early puberty, could be because the puberty comes on with the male hormone first. So the male hormone in the blood, which is coming from the adrenal glands, is causing the puberty. Adrenal glands are glands on the kidneys which produce the male hormone. Because the ovaries are still not active before puberty. Once the ovaries become active, then the estrogen comes into circulation. So if a girl has reached an early puberty, or if there's childhood obesity, where the children are very obese, like many mothers think that if my child is nice and cute, chubby looking child, they are very happy to see their children cute and chubby, which is not the right thing. Even if they are chubby, they must be exercising, they should be eating correct food rather than eating wrong food. So children who are obese, girls who have reached puberty early at age, normal age is around 12 years of age. If the girl reaches puberty at 10, there is a possibility that she could be heading for a PCOS. Third is that she goes on putting on weight after reaching puberty. And then acne and all, that's why there's a confusion in teenagers. We don't make a diagnosis of PCOS unless we are sure. We consider them at risk because they've got a lot of acne which doesn't go easily. It's continuously there. Whilst girls who are teenagers who get it because of their hormones coming up usually happens before a period, and then it tends to go away after a period. So these are all suspicious areas where you think of patients may be having PCOS. You don't do an ultrasound at that time because the ultrasound will show you polycystic ovaries. So we don't do that at that time. Third is, of course, if her periods are going crazy, absolutely. She's not bleeding. First year after puberty, most of the girls have erratic periods. We don't worry too much about it unless she's bleeding very heavily, which needs medical attention. And she needs to, check out what are the reasons for her heavy bleeding. At that time, we do the ultrasound. We check if there's a cyst in the ovary. We do a hematological evaluation, whether she's got a bleeding tendency. But history of irregular periods in the first year is very common. Usually within 2 years, it should settle down. So a girl, if she's got a period at 12 and she's still at 14, she's still having erratic periods. That means she's at risk of PCOS. It could be other reasons also, but you put all the facts together and then take a call as a doctor. But only one symptom is not going to let you know which girl is going to get PCOS. Putting on weight, another symptom, especially on the waist, that's a third symptom. So there are various such symptoms which will be there, but it needs to be put together into a cluster rather than just by one. If you're preparing something on an app or a platform, you cannot talk about one symptom which can cause the problem. Which could be representative of PCOS, right? But if a young girl has got all three, if on ultrasound it shows polycystic ovary, she is getting erratic periods and she's having a lot of hirsutism on her face, then definitely she needs to see a doctor because PCOS is a diagnosis made out of exclusion. You have to rule out all the other disorders which have got extra male hormone in the body. So unless you do that, you cannot say this is PCOS. You can only say you are at risk. See a doctor. Period. Yes, please.
So as far as the medical question, but since hyperandrogenism is one of the features of PCOS, do you recommend getting the tests done to prove, getting your DHEAS or proving insulin resistance by blood tests, or just a clinical evaluation is enough?
To be honest with you, these hormone levels are so important to do, and they have to be done. If you see how the hormone levels are done in different labs and different, sort of setups, if it's done in a lab which is not done with a good hormone kit, okay, if it's a lab wherein, proper standards are not followed, you may get totally erratic results, and you cannot depend on those. You can depend on the clinical appearance, but we don't depend only on the hormones. But unless a hormone level comes from a good lab, where I know it's a hormone lab, or it's done in a research laboratory with high-end equipment, then I can depend on that. But that is why even according to the guidelines, they say if there is clinical impression of hyperandrogenism, then there's no need for you to do the test. But I get it done for all my patients because I use a good lab, number one, and I monitor the patient in the same lab. So if I'm giving her some therapy, whether she's responding to my therapy, I will know only if I study the hormone levels. But to make a diagnosis, I don't need it if she has all the symptoms of hyperandrogenism. Same holds true for the insulin. Sorry? Somebody said something. Yes, please.
Thank you so much, first and foremost, for the presentation. I think the 2018 guidelines were gospel for me when I was back at Monash. Can't wait to see what the 2023 guidelines hold. I guess my question is more from the management side of PCOS. There are, like as Rotterdam criteria, there are a lot of, there are 3 diagnostic features for PCOS. And there's also a phenotype for PCOS, the 4 different phenotypes. So my question's mainly, is there any management specific for each phenotype? Is that something that's covered in the 2023 guidelines?
Not really. It's nothing to do with managing a phenotype.
Okay.
So a phenotype could be a combination, say, of oligoamenorrhea, that's irregular periods. The classic thing is when you have all 3. where you have high androgens, you have irregular periods, and you have the polycystic ovaries, all three together. So now there's no one treatment for that, right? You are going to treat her irregular periods by treating her hormones. You're going to treat her androgens by reducing the male hormone. You're going to treat her polycystic ovaries. You can't change that look, whatever is there. So when we treat them, usually we treat them with oral contraceptives. It works brilliantly, provided it's not contraindicated. So they get their regular periods. With the oral contraceptives, the ovaries start reducing in size, and they're not as large as otherwise. The male hormone comes down. It's a brilliant drug for PCOS patients, and therefore we put them on oral contraceptives, but provided we have made sure that it's not going to harm her, it's only going to help her. There are certain contraindications we have to take care of, and that's it.
So would you say that PCOS management is basically symptom management?
Yes.
At the end of the day?
Yes.
Oh, perfect.
It's mainly symptom management, but at the same time, lifestyle change is the basic management. That has to be done. Without that, you're going to constantly be treating, because the mothers keep asking, how long, doctor, can I give her the OC pills? I said, the day your daughter reaches her normal weight, I will start stopping all the drugs. I will put her off. And I've had many patients whom I've been able to completely stop all medication. And they've become, sort of our, champions who talk about PCOS quite openly. Others, many girls are not happy to talk about their medical condition.
Agreed. Thank you.
Thank you.
Yes, Anu.
Thank you very much, Dr. Shah, for a brilliant presentation. And I wanted to ask a question on behalf of the tech community who is here. So how do you see technology, as in digital or whether it's app-based or whichever, really helping to bridge the gap that you mentioned, that PCOS awareness is low not only in patients, but actually also in practitioners also?
Yes.
So what is the best way to educate practitioners?
I think the best way we treat this thing is we do a whole lot of webinars, we do a whole lot of master classes, we do conferences, we have educational content sent to them. So we do educate them, but it's going to take a while before we do it. I think in the 7 years that we have been in existence, I think we have achieved quite a bit. At least now many people don't say PCOD. That word PCOD is a disease. We don't use that word now. Everyone started using PCOS. And there's a world of a difference between the two terminologies. So in short, teaching everyone, you see, family physicians, they are the first people we need to teach. And it's difficult to reach out to them and get them to be interested in the subject. You do conduct seminars for them. They go for many seminars, but I don't know, they have to get motivated to tell a girl that I think you have this problem, let's investigate, or let's send you to the consultant, or let's do these tests, let's do this, let's do that. But it will take a little while to get them to get educated. So I think the education part has to come from the organization, medical organization, which we do. And where it comes to consumers, I think yes, a lot of social media will help, but what I see on social media is sometimes not correct. And I think that wrong information shouldn't be going out. So it can bridge the gap where consumers are concerned if the right information goes out.
Thank you very much, Doctor.
Hi, Dr. Shah?
Yes.
I'm right here.
I'm trying to see where you are. The lights are staring in my face.
Okay.
Yes.
So there are a lot of digital, apps, I would say, which help in managing PCOS. I don't know how the uptake is. I don't see anybody in the audience who is specifically focusing on PCOS. But as a doctor, do you have any recommendations? Because see, lifestyle change is very, for a doctor to say that you need to do this may not be, I'm not saying it's easy, but it's an advice. The onus is up to the patient and the patient's family to actually make those changes. It's very hard because as young girls, and I have one in my own family, they are in their 20s, they don't care. When you talk to them about, okay, PCOS might affect your fertility, there's like, we're not having children. that's the first reaction of young girls and teenagers now, that we don't really care because we're not going down that path. And getting them to actually stick to a regimen, whether it's diet, whether it's lifestyle. And diet, I mean, it's super hard because all you have around you is junk. So, you know, there are many apps in the market which help you regulate your entire day and give you those nudges to maintain a healthy lifestyle. So, as a doctor, have you experienced such, you know, what do I say, technology supportive, you know, tools that you are using or recommending to your patients?
As a matter of fact, currently what we do is we give them the advantage of having a nutritionist on board. We have the fitness person on board. We have a counselor on board, so who can counsel them related to their anxiety, etc. So we make every effort for an all-round effort. And we show them on their scale. We have the biometric scale. So it shows them how the fat has been reducing, how the muscle mass is increasing. I think showing them something is very important because they see what is going on. And these are girls who are really motivated. Now, if you're talking about girls who have got PCOS and are still not motivated, then we need to motivate them. I think it has to come from within the family. I tell the parents, don't bring any sweets at home. They said, what difference? She'll go and buy it from outside. Right? So schools have been told not to keep unhealthy foods in their canteen. But I don't know how many schools follow that. That's a recommendation from the health ministry, that the fried food, at least the good schools don't have it in their canteens. So that is important. But once they go to college, then it's like there's no monitoring at all. So the monitoring has to come, probably some kind of example you have to set for your children. Like say, if I'm going to stay healthy, I'm going to see to it that my patients and my children remain healthy. But if I'm not bothered and I'm going on hogging away and I'm putting on weight and I'm telling her you don't put on weight, it's sometimes not taken easily. So in short, you have to become a model for your own children, and you have to do it. And that's what I believe in. I think if you see someone, within the family doing it, it makes a difference. You cook food accordingly. But yes, after all, teenagers are teenagers. They are going to party. They are going to go out. But that's not every day. No? They'll go once a week or maybe twice a week. But during the week, if one is disciplined and one cooks food accordingly at home, even if you're not cooking yourself, you're telling your cook to make it. But think of recipes so the nutritionist actually gives them recipes. So it's easy for the mother also to follow those. So it works well when you get ready-made plans in your hand. Nowadays, there are a lot of people doing, there's a lot of, areas where they have digital help with exercises. I think there are a lot of centers which are offering digital exercise, like say online. They can do it online, they get a program, they follow the program. But unless there is a willpower to do it, they will not do it. So the only way you can, tell them about what can go wrong if they don't do it. And then you give them examples of girls who have had this problem, or they are shaving every single day. I mean, we tell them that. And you want to see, we sometimes show them pictures, of course, not of our real patients, but some other pictures. See, just like I showed you, that this is the kind of hair growth you're going to have. Are you happy to have it? And things like that, in short, you have to motivate them. And somehow I've found that almost 75-80% of the people we are able to motivate. Can't. Just use the mic, please.
Thank you for the presentation. There's just one question, that once the person gets on the lifestyle management process, so is the weight only biomarker that we look at to identify if the treatment plan has been effective, or do we look at other factors also?
I didn't get your question correctly.
Okay.
Your voice is not carrying through easily.
Okay. I'm saying once a person gets on the lifestyle management thing, so is the weight only biomarker that we look at if the plan has been effective, or do we look at other biomarkers as well? Because we have seen cases wherein the person has been, they're on a lifestyle management plan for 6 months, 7 months, wherein they have not been able to lose effective weight, but the periods get on time.
Yes.
After that, they tend to lose that, momentum that they have had. So how do we look at it?
So that's one of the biomarkers wherein the periods become regular, which is a great biomarker. When their periods become regular, then they understand that by losing weight or by exercising, it's helping them. Even if the weight doesn't go down, they're probably building muscle. And that is why we do the biometrics, because if we show them that the fat is going down but the muscle is building, and muscle is heavier than fat, so that helps them to understand, yes, what really is happening within their bodies. They say, oh doc, I'm not losing weight. I say, are you losing inches? They say, yes. So that's the answer. So in short, they lose inches, they may not lose weight because their muscles are growing better. So that is one good biomarker whether periods are coming regularly. The second thing is, I find that when I talk to patients, when the first time they come to me, I ask, especially if they have a lot of facial hair, we score it. We call it the Ferriman-Galway score. And if it's anything above 8, means it is definite hirsutism, which is androgenic. So what we do is we score it for the first time, and we ask questions as to how often do you remove your hair from your face. And honestly, no girl will allow her hair to grow long. If you see medical literature, it says if the hair is more than 1 centimeter long, you can say that this is hirsutism. I said, which woman is going to allow her hair to grow to 1 centimeter? Nobody. So what I have evaluated my own way of looking at it, how often do you remove your hair? Because every girl will take it out when she feels is the right time for her. So if the first time she's come to me and she says, I removed my hair, whether she's doing laser, she's doing waxing, she's doing shaving, whatever she's doing, if she says, I'm doing it once in 8 days, then after I've given her the therapy, after she's medications, after she's lost some weight, we again evaluate, say after 6 months, because hair growth takes about 9 months for the hair to grow. So evaluating early is of no use. So after 6 months, we again ask her when she comes back, how often are you removing your hair? Then she may say, oh, once in 20 days. Or then she, you know what I'm trying to say? That becomes a good marker for me to know that she's doing well. I can't wait for 1 year for her hair to grow back and then see. So in short, these are small tips which help me to decide whether she's responding, she's not. Of course, I do their insulin levels, I do their male hormone levels, because I think that gives me an idea of what really is going on in the body, but it's not mandatory to do it. So I think that becomes a good marker, how often she's removing the hair, right? How often is she getting her periods? And those are very good biomarkers.